One of the hardest things to do in clinic when faced with a new patient who complains of shortness of breath is to decide whether or not the symptoms are due to the heart, to the lung, or both. But if you think the symptoms are due to the lung, we must begin to realize that COPD, or chronic obstructive pulmonary disease, as well as asthma, can sometimes overlap. And it's estimated, at least in our experience here at UC Davis, to be between 15 and 25%. However, the Global Initiative for Asthma estimates that the overlap may be as high as 55%. So I think we need to look for both diseases when patients complain of shortness of breath, cough, and or wheezing. Look at the patient, listen to the symptoms, weigh the contribution of asthma and COPD in a patient before deciding. And if patients have enough of both categories, then they have the asthma COPD overlap syndrome.
One of the intriguing things that we have noticed in the last 30 years is that smoking rate amongst asthmatics is the same as normal population. As a result, when these asthmatics enter ages of 40, 45, 50, or 60, they develop COPD. So physicians are challenged by seeing a patient who has COPD and history of asthma.
Another common situation is when certain patients with asthma, as they get older, develop fixed chronic obstructive disease. So that's a different form of COPD asthma overlap. So those two, I think, are important categories which we need to identify and treat, emphasizing maybe inhaled corticosteroids in those kind of patients.
The fact that treatment of asthma and the treatment of COPD is really two different things creates a challenge. We normally treat asthmatics with inhaled steroids, and the COPD is really treated with long-acting beta or long-acting anticholinergics. So treating an asthmatic who has COPD is much more difficult than treating an asthma alone or the COPD alone. And the reason is that we normally treat COPD patients with, at least at early stages, we treat them without use of ICS or inhaled steroids. However, inhaled steroids is the mainstay of therapy for asthmatics.
There are a couple of situations where I find that the overlap is not really there and people are getting misdiagnosed with asthma and COPD. One example is, for example, when we look at pulmonary function tests and reversibility, you can see partial reversibility very commonly with COPD when you give these patients a bronchodilator. Unfortunately, many of us would then tend to used to label them as asthma along with COPD, but several studies have shown that that's not the case, and we should not be calling them both asthma and COPD. Another common kind of overlap diagnosis, which may not be correct, is individuals who had childhood asthma and atopy and completely outgrow it, and then go on to develop COPD again because of tobacco smoke or occupation exposures. Again, in those individuals, I think we should be careful in not calling them asthma and COPD just because they had childhood asthma.